Assalamualaikum warahmatullahi wabarakatuh. My name is Nuradila binti Ibrahim. I'm from Bachelor of Medical and Health Sciences from OUM Petaling Jaya. Today I would like to share with you guys about anterior hip dislocation. Okay, at first we have to know what is hip dislocation. The hip is a ball and socket joint. The socket is formed by acetabulum, which is part of the large pelvis bone. The ball is the femoral head, which is the upper end of the femur, or we call thigh bone. A smooth tissue called articular cartilage covers the surface of the ball and the socket. It creates a low friction surface that helps the bones glide easily across each other. The acetabulum is ringed by strong fibrocartilage called laberum. The laberum forms a gasket around the socket, creating a tight seal and helping to provide stability of the joint. Dislocation of the hip is a common injury to the hip joint. Dislocation occurs when shape of head the femur comes out of the cup-shaped acetabulum set in the pelvic bone. This injury may happen to a varying degree. Okay, next is what is anterior hip dislocation? When there is a hip dislocation, the femoral head is pushed either backward out of the socket or forward. There are two types of dislocation, which are posterior dislocation and anterior dislocation. Anterior dislocation may happen when tight bone slip out of its socket in a forward direction. The hip will be bent only slightly and the leg will rotate out and away from the middle of the body. When the hip dislocates, the ligaments, labrum, muscle, and other soft tissues holding the bones in place are often damaged as well. The nerves around the hip may also be injured. Okay, there is one patient I've attended during my clinical posting for pre-hospital care at Hospital Sultanah Bahia, Alostar. Patient with alleged MVA motorcycle versus car. Patient was riding alone motorcycle, wearing helmet, not under alcohol or drug influence, unsure of mechanism. Okay, for post-trauma, patient no loss of conscious, no retrograde amnesia, complaint left over left arm and leg, no neck pain, no weakness and no numbness. History of previous illness, no known medical illness. History of family illness, father has gout, mother has hypertension and diabetes mellitus. No history of doing surgery. Okay, for social life, social history, patient live with her family. Non-smoker, non-alcoholic, and unemployed. Patient have no history of allergic reaction, no history of taking traditional medicine. And for provisional diagnosis, patient alleged MVA with anterior hip dislocation, deep laceration wound at the left elbow, and multiple abrasion wound. For differential diagnosis, patient have maybe femoral neck fracture, hip subluxation, bony contusion, slip capital femoral epiphysis, and pelvic fracture. Okay, for physical examination, generally patient alert, conscious, GCS full 15/15. Patient have no tachypneic, pain score a bit high 8/10. All the vital sign normal. Okay, on inspection, overhead has abrasion and bruises was found. On palpation, no tenderness and swelling. For face, no injury, no bruises found. Palpation, no tenderness and swelling over face. For arm inspection, there was a deep laceration wound with minimal bleeding on the left arm. On palpation, no tenderness and swelling. For leg inspection, found abrasion wound on the left leg, and there was a deformity on the hip area, on the left region of the hip. On the palpation, there is no tenderness and swelling, and also pelvic spring negative. Okay, for finding using the upper and lower limb test, for upper limb, the power, sensation, and muscle tone are normal. Power 5/5, sensation intact, and muscle tone normal. For lower limb, on the right side also normal, but for the left side a bit low for muscle tone. So the finding of the X-ray for the cervical and chest X-ray, no fracture seen, no cardiomegaly, no rib fracture, no clavicle fracture. For the left humerus, also no fracture seen. Left wrist, no fracture seen. Left femur, it show there was a hip dislocation, maybe anterior hip dislocation. For the left knee, no fracture seen, and also pelvic, no fracture seen. Okay, for PHC management. PHC management first always remember danger. Make sure location clear from danger, no hazard, and responder always wear personal protective equipment or PPE, especially during pandemic outbreak like now, because we don't know the patient status, we don't know the patient have contact with positive patient or not. So always wear your PPE before attend patient. Make sure patient in a safer place before further assessment. Number 2 is a response. Call patient to make sure patient alert and conscious. Ask patient, are you okay? Okay, if the patient not opening his or her eyes, tap patient's shoulder and ask, are you okay, sir? Okay, for this patient, I've attended this patient alert and conscious and able to communicate with me. Okay, third is airway. Check whether patient's airway pattern or not. Look for any trachea deviation or not. Look for any foreign body inside the mouth. Okay, for patient I've attended can talk, so it was considered the airway was cleared lah. Apply cervical collar to protect patient's cervical since the mechanism of the MVA was unsure. Okay, we also can auscultate to make sure the air entry for both lungs are equal. And then fourth is breathing. Inspection. Observe how patient breathe. Look for any sign and symptom of life-threatening injury like atom FC. Look, a patient having tachypnea or not. And then do the percussion. Listen the sound of the chest wall, whether it was dullness, resonant or hyper-resonant. And then do the palpation. Abdominal palpation was done to detect any free fluid and position of the kidney and the liver. And then is auscultation lah to make sure the air entry for both lungs are equal. Okay, number 5 is circulation. Monitor patient vital sign and find any sign and symptom of shock. Control active bleeding and pack with gauze, especially on the laceration wound on the left arm. Check patient's pulse volume, whether it's low or strong. Noted patient's pulse rate, either it's tachycardia, bradycardia or normal. And check capillary refill time, CRT. If less than 2 seconds, is considered normal. And then look for other abnormalities. Pelvic spring was done and negative, but the pelvic binder was applied since there was an abnormalities on the left head of femur, on the left region on the hip. Suspected hip dislocation, and then move patient carefully to the spinal board. Okay, recheck patient's CRT on the left leg and also right leg, and also check pulse on the both leg to find any abnormalities. Observe patient's leg color to make sure the blood flows smoothly. Noted patient's pain score. For this patient, pain score 8/10. Next is consult an ECC for painkiller in order to reduce the patient's pain. Ask patient last meal and allergic history before gives any drugs. Transport patient immediately to hospital and tagging patient yellow zone. Why yellow zone? Because this patient considered stable and no other serious injury. Also inform MECC estimated time arrival so that they can prepare whatever needed. Lastly, always monitor patient's vital sign before and after painkiller giving. And on the way to hospital, always monitor patient's condition. Okay, for suggestion and solution. First, of course, for hip dislocation or any other dislocation, we must do the reduction. For anterior hip dislocation, we can do the close manipulation reduction. For close manipulation reduction, we need 2 persons because there was one person will downward pressure the pelvis and the other person will do the external and internal rotation and then upward pull the femur like this. Okay, and then following the reduction lah, someone have to give the pressure downwards and someone have to pull outwards. Okay, and then post reduction management. Some investigators recommend a temporary period of traction or balance suspension until the patient's initial pain has subsided. After this, control passive range of hip motion exercises and early immobilization are thought to be benefit the patient's overall condition. Extreme motion should be avoided for 4 to 6 weeks to allow for capsular and soft tissue healing. Surgical intervention. Okay, surgical intervention should be performed if close reduction is unsuccessful, bony fragments or soft tissue remains in the joint space, or the joint remain unstable. Thoroughly irrigate the joint to assure adequate cleansing of any loose bone fragment or soft tissue that would prevent the proper articulation. Hip arthroscopy can be used to remove intra-articular fragment, evaluate intra-articular fractures and chondral injuries, and also repair labral tears. Okay, lastly is rehabilitation. Within 5 to 7 days of the injury occurrence, patients may perform passive range of motion exercise to increase flexibility. Walking aid should be used until the patient is comfortable with both weight bearing and range of motion. Okay, for complication, hip dislocation, anterior hip dislocation also have complication. First, it can cause nerve injury, osteonecrosis, arthritis, and also factor predisposing to poor result. There was also a factor that can lower the result of the CMR, like older child, severe trauma, delay reduction which is more than 6 hours, incongruous reduction, and AVN. Okay, for conclusion, hip dislocation are common injury that result from high energy mechanism. This patient require careful trauma evaluation to rule out concomitant injury. Early immobilization by PHC team and reduction within 6 hours plus close radiological follow-up is recommended to avoid serious complication. Anterior dislocation without femoral head injury have a better long-term prognosis than posterior dislocation. Okay, and that's all from me. Thank you.